Hi everyone, this is Danielle. I'm going to be doing the GI exam today. I've got my marker, my measuring tape, and then a stethoscope as my equipment. We'll get started. All right, so with the GI exam, position is important. You want to make sure that you are on the right side of the patient and that they are supine, which in this case, my husband is. Okay, and then for the GI exam, you want to make sure that you start with inspection, move to auscultation, then go to percussion and palpation. 3 different types of palpation. You've got light, moderate, and deep. If your patient is complaining of any pain, make sure that you do any areas that are causing the pain or discomfort. You do those last. You want to percuss and palpate those last to decrease pain or any guarding. Okay, so we're going to inspect. We're going to inspect 3 things right off the bat. First one is something called colon sign. It's going to be if there's any ecchymosis around the umbilicus. This could be indicative of acute pancreatitis. So if you see any bruising around this area, or it could be a ruptured ectopic pregnancy. And then Gray-Turner sign, which will be any ecchymosis in the flank areas on either side, which could be indicative of a retroperitoneal bleed or again acute pancreatitis. And then we're also going to be looking for any abdominal distension. An abnormal finding would be distension, and that could we look at 9 Fs, 5 of them being flatus, feces, fibroid, fetus, or a fatal tumor. Okay, moving on, we're going to be auscultating. So auscultation, we're going to start with the diaphragm on my stethoscope. We're going to be listening for vowel sounds. 4 quadrants, starting on the right lower quadrant, moving up to the right upper quadrant, to the left upper quadrant, to the left lower quadrant. Absent vowel sounds could be indicative of an ileus or peritonitis. Hyperactive vowel sounds could be indicative of gastroenteritis or GI bleed. And then high-pitched tinkling sounds could be indicative of an obstruction. Excuse me. Moving on, we're going to auscultate the aorta. The aorta sits above the umbilicus, about 2/3 below the xiphoid process. We are going to listen to that with the bell for a brew. After we've listened to it, then we're going to palpate with both hands, and we're just going to feel. If we feel anything greater than 3 centimeters, that could be indicative of an aortic aneurysm. Okay, and with the brew, you know, it's a whooshing sound. Okay, moving on. So we've auscultated and palpated the aorta. We're going to be moving on to the liver. The liver kind of sits behind that right lower rib cage. The first thing we're going to be doing is percussing the liver. The first percussion test is we're going to make some marks with our marker, and we're going to need to use our measuring tape. So you're going to percuss up till you hear a dullness, mark it, and then you're going to do the same but going down. Mark it. This should measure about 6 to 12 centimeters. His is about 10. After that, we're going to do the scratch test. The scratch test, you're going to use your stethoscope with the diaphragm. You're going to go below the xiphoid process. You're going to scratch up until the sound is louder. Hold on, make sure my stuff. Mark that. And then keep scratching until it gets less. About there. And then you're going to measure that. That should be about 10 centimeters. Let's measure it. And that's about spot on 10. Okay. So that is the scratch test. After we do that, we're going to palpate the liver. You're going to do some deep palpation, and you're basically just trying to find the outer edge. It's hard to feel the liver. Typically, you won't be able to, but you just want to feel if there's anything that's really hard or irregular in shape. Liver feels good. Okay, so we're done there. And then we're going to do the fluid weight test. You're going to ask your patient to put their hand kind of middle of their abdomen, and you're going to palpate on one side and you're going to tap on the other. And if there is a fluid shift across that is felt on the other side that's palpated, then that's an abnormal finding and it could be indicative for ascites. So that is the fluid weight test. Moving on, we're going to check the gallbladder. Gallbladder kind of sits right near the liver, and that's going to be in the right upper quadrant. And the first way or the only way really, the Murphy sign. So Murphy sign is an abnormal finding and can be indicative of cholecystitis. The way you do that is you're going to really push up under the ribs on that right upper quadrant. Ask your patient to take a big breath as you're doing it. So take a breath. And if they stop mid-inhalation when you're doing that because of pain, then that could be a positive Murphy sign. All right? So he doesn't have any pain. He's not positive with the Murphy sign, so we're good there. Moving on to the spleen. The spleen is going to be found on the opposite side of the patient, on the left side. So we'll kind of turn. And this might be kind of hard to show, but with the spleen, it sits at the lowest intercostal space, so at the bottom of the ribs, and anterior axillary line, so kind of right there on that armpit area. Can you see on there? Okay. And with the spleen, you're basically feeling if there's any kind of like rigid area, anything on that side. And one way we check, see if there's anything wrong with that is, again, we'll percuss. Can you still see me? Mm-hmm. See my hands? Okay, so kind of right there in that space, you're going to percuss, and the lung is going to be resonant. So what you're going to do, so I'm tap, tap, tapping, and then you ask your patient to take a breath. And if you hear any dullness, then that could be indicative of an enlarged spleen. And then you're going to want to palpate your spleen. You're going to do that by kind of pushing all around under that rib cage, and then it's going to deep, and then you're going to have them turn onto their right side, and you're really going to try to get in there, and again, palpate deep up in there to see if there's anything enlarged causing discomfort. Really, you should only be able to feel the edge. And so that is the spleen. Moving on, we're going to be checking for McBurney's point. McBurney's point is checking for acute appendicitis. That one is going to be about, if you can pan to the belly, McBurney's point is about 2/3 from the umbilicus, kind of pointing down to the hip or the ASIS. So about here. And as you push it, if it causes any, this is McBurney's point, if it causes any discomfort, tenderness, rigidity, or you feel rigidity, then that's a positive McBurney's sign. So pushed on that. And then also with appendicitis, you're going to be, the other signs are going to be something called Rovsing. Rovsing is you're going to be pushing slowly on the left lower quadrant. And as you're pushing, if they have any referred pain in that right lower quadrant, then that's considered an abnormal finding or a positive Rovsing sign. Then we're also going to be checking for rebound tenderness. The way you check for rebound tenderness, sort of the same, I think, or idea as Rovsing, but you're going to be pushing down, and then as you lift up, if they have any pain in that right lower quadrant, then that is a positive rebound tenderness sign. So you'll push down, ask your patient, are you hurting as you let go? No. Okay? You're not having any pain.
No pain.
Okay, so those were the for appendicitis. Then there's a couple more with appendicitis, one being the psoas sign. So if you will, if you can sit up, this one we could put on the table. For the psoas sign, you're gonna, and I hope I'm pronouncing it correct, psoas, P-S-O-A-S. You're gonna have your patient sit, watch your head, and with the, here, can you sit over here?
Or I can sit in this chair.
You can't see that, sit over here.
Okay.
You're going to sit on the table.
Sorry.
Sit on the table, and then basically you're gonna try to lift your right leg up, thigh up as I push down. And if you have any pain, you can keep your leg bent. Try to pull up. If you have any pain in that right lower quadrant, then that could be indicative of, again, appendicitis. And then the next one is with your patient laying down. This one's going to be kind of hard to see, but you're going to internally rotate the right hip. The way you do that is you're going to pull the right ankle towards you and push the right knee away. And as you do that, if the patient has any pain in that right lower quadrant, then that also is indicative of appendicitis. Last thing we're going to do is check the corticovertebral angle, which is checking for pyelonephritis or kidney infection. The way we do that is, I don't know where my marker just went, but we're going to be looking at the back of the patient. We're going to go to the 12th or the last ribs. And what you're going to do is you're going to palpate down. His ribs kind of go far down. And about there. And so you're going to kind of make that angle between the spine and the ribs. That's a little bit, I don't know if you can see that so well, but I'm kind of make it a little bit bigger so that you can see in the video. You see it? Okay. So with that, bottom of the rib cage, you kind of have this 90-degree angle. You're going to do an open hand on one side, and this is the best way I've seen it. And you're going to fist bump. So you're percussing on both sides. If the patient has any tenderness with that, then that's a positive sign or an abnormal finding for pyelonephritis. And that is my GI exam. Y'all have a great evening. Thanks so much. Bye.